Thank you again. So this is the last, so hopefully everybody's enlightened for just a few more information. Hopefully it's not going to be much crowded, and try to make it smooth as possible. So this is going to be a case-based approach about calcium and bone health. And here I'm putting several diagnoses in one case, which is actually a true case. I added a few parts which made it more appealing, but the bulk of the case is actually a true presentation. These are my disclosures. So this is a 72-year-old Kuwaiti female who's referred for a colleague for recommendation regarding osteoporosis treatment after screening by a DEXA scan by her primary care physician. She's known to have a type 2 diabetes with no known complications. She has other medical conditions including hypertension, dyslipidemia. She has a multinodal thyroid goiter with a benign cytology that was done with a cytology evaluation about 10 months ago. She has no history of low trauma fractures, but she has her mother who had a hip fracture after a slip and fall accident. In review of system, she has negative for fever, weight loss, abdominal pain, diarrhea, or even hematuria. She complains of fatigue in most of the days. She has occasional dysphagia, thought probably related to her thyroid goiter, and difficulty in breathing also when supine. Her current medications include omeprazole for her some GERD symptoms. She's on valsartan 160 milligram for her hypertension. She's on metformin and sitagliptin for her diabetes, atorvastatin for her dyslipidemia, meloxicam as needed for pain, for joint pain, and cholecalciferol, about 800 units, international units daily. On physical examination, her weight and height gives her a BMI of about 18.9, which is slightly on the low side. Her neck showed a large multinodal goiter, mainly on the right side, larger than the left side. Her trachea shifted a little bit to the left side, but not extending beyond the clavicle. She had chest and abdomen examination were within normal. Spine curvature looks normal without kyphosis or vertebral tenderness, and she had no other abnormalities were detected on the physical. Her laboratory test shows a calcium and an albumin that gives her corrected calcium of 2.6. A phosphate of 1, and a creatinine was normal. Her intact PTH was 55 picogram, and her 25 hydroxy vitamin D was 80 nanomoles, which is within normal limits. Her urinary calcium within 24 hours was 250 milligrams, and her urinary creatinine was 7.1, so slightly lower than normal. Fraction excretion of her calcium was about 0.025, and we'll get into that later. Her DEXA scan shows, which is basically the reason for her visit. Only a summary report was available. There wasn't the full evaluation was completed. So she had a lumbar spine T-score of minus 2.1, a right femoral neck T-score of minus 2.4, right total hip T-score minus 2.1, and the left proximal 1/3, which is non-dominant forearm in her case, was a T-score of minus 3.5. So does she have osteoporosis? Well, probably she does. If you screen different guidelines of how to diagnose osteoporosis, this is a consensus statements from the GCC countries with the ISCIO help, looking for evaluation for diagnosis for postmenopausal women with osteoporosis. So there are 3 ways you can diagnose osteoporosis based on this consensus. You either do a T-score assessment by a DEXA scan, and you can have a minus 2.5 or less standard deviation, either in the femoral neck, spine, or distal radius. You can actually diagnose it even with increased risk of major osteoporotic fracture, what we call above the upper assessment threshold based on the country-specific FRAX score, or above an intervention threshold if the value of BMD has been measured. And it's a specific model for specific patient and country. Or the patient has a presence of a fragility fracture, especially at the hip or the spine, that would diagnose osteoporosis. So our patient does have a standard deviation of less than minus 2.5 at the forearm, a distal radius, which gives her one way of diagnosing. But we want to evaluate also if her risk for fracture is actually elevated based on the FRAX score. So FRAX score is basically a 10-year assessment of a probability of a major osteoporotic fracture, which includes spine, hip, forearm, lower limbs, and also a hip fracture. It's incorporated in many guidelines, and now it's because it's a country-specific, many countries have now estimated risk for fracture. So she's from Kuwait, so that's how I will label her in terms of country-specific. Logged in her age, sex, BMI, a parent with a hip fracture, she does have diabetes, and you can actually, at number 9, which is rheumatoid arthritis, you can click yes if the patient has type 2 diabetes, because either one of them would give similar risk factor for fractures. T-score of minus 2.4, that gives her a major osteoporotic fracture risk of 15% and hip fractures 9%. So is that high or appropriate or normal? So that basically goes when you have an intervention threshold assessed and actually shown to be effective. So we published our intervention threshold in Kuwait back in 2017. And what we mentioned is that if your patient is actually, well, there are 3 specific lines you need to know. The lower assessment threshold, which is the line separates the low risk individuals in green from the moderate risk individuals or high individuals in orange. And then you have the upper assessment threshold, which is the line that separates the orange zone, which is moderate or high, compared to the ones with the very high risk in red. And then you have the dotted line in the middle, which is the intervention threshold, and that's requirement if you have a BMD evaluation to give you the risk for fracture. So our patient scores 15%, which is higher than the upper assessment threshold. She's in the red zone. That gives her an indication for treatment because her risk for fracture is actually very elevated. So based on T-score, she has diagnosis. Based on risk for fracture, she does have osteoporosis. The selection of a therapy then would probably match her risk for fractures. This is a kind of gathering of many guidelines internationally produced looking for the risk of a fracture and what would be the choice for therapy. Now, our patient can be considered as a very high risk, considering that she has a T-score of her forearm that is minus 3.5, and one of the items of selection for a very high risk in this slide here showing that the very low T-score that is lower than a minus 3, that's an indication for a very high risk. And even when she scored at the risk assessment with the FRAX, she also scored as a very high risk for fracture. So basically the appropriate therapy for this kind of conditions would be starting with an anabolic therapy. So she goes into the first line, very high risk individuals. So preferred treatment would be a romosozumab or a PTH, which is a teriparatide. So romosozumab is a sclerostin inhibitor. It's a monoclonal antibody. It helps for bone formation. It has also an anti-resorptive effect for the first 1 year of action, or anabolic effect for the first 1 year of action. So that's why it's limited to 1 year therapy. Teriparatide is analog of parathyroid. It can be used up to 2 years. It has an anabolic effect if it's used on a daily use, and that would be the selection for therapy, either one of them. Because of the easiest, at that point, it was easy to get the parathyroid hormone as a treatment, so patients on her clinical history and risk of fracture, she was started on teriparatide. 3 weeks later, she comes with symptoms of fatigue, nocturia, and she has serum calcium concentration to be 2.8 millimole. She went to the lab and did further blood tests, and she came with a corrected calcium of 2.9. Phosphorus was 1.1, which is still normal. Creatinine slightly increased from the last visit, but still within normal range. And her intact PTH was within normal range, slightly on the upper level, just like the previous test. So further testing, we wanted to evaluate whether she does have a true hypercalcemia. So we done the ionized calcium, came back to be positive, to elevated 1.8, and her alkaline phosphatase, which was one bone specific, was also elevated 120. So that gives us impression that this patient, if we recap her initial test, and from the initial time, initial visit, she has a corrected calcium of 2.6. She has phosphorus, which was normal, even though slightly on the lower range, and her PTH was normal in the upper range. So that's probably can give her a questionable PTH-dependent hypercalcemia, or maybe even a true diagnosis of a primary hyperparathyroidism. Now, she has a fraction excretion to be 0.025, which actually goes with patients not having an FHH, which is the familial hypercalcemic hypercalciuria, which is for that specific diagnosis, you need the fraction excretion of calcium to be lower than 0.01. But she scores higher, that gives her an indication that's probably this is a primary hyperparathyroidism. The left proximal 1/3 of radius showing a minus 3.5, and we know that forearms usually composed of cortical bone, and parathyroid hormone, which is when it's elevated in primary hyperparathyroidism, the main action or the main cytology, or the histology that actually works in most is the cortical bone. So bone resorption will increase in the cortical bone areas compared to the trabecular bone. So you will see the effect more in the forearm, more than the spine, because of the trabecular bone in the spine and cortical bone in the forearm. So based on the pre-treatment biochemical and the DEXA data, this patient has a diagnosis of a primary hyperparathyroidism. She has an elevated corrected calcium, ionized calcium is elevated, PTH is not suppressed, and she has a greater deficit in the cortical-rich proximal 1/3 of radius. So following the initiation of the teriparatide, patient developed further hypercalcemia, and in fact, teriparatide would be contraindicated to be used in this situation of patients because they do have hyperparathyroidism. So that's adding into the pool of calcium, when an elevated calcium. So here what the situation in this patient happened is that she had already high PTH, and we gave her an anabolic effect of PTH action that increased the bone resorption and increased the serum calcium. Also, it activated more vitamin D, so conversion of 25 to 125 dihydroxy vitamin D was higher. That's increased the GI absorption of calcium and phosphorus also, and also reabsorption of calcium from the kidney. And that's what also caused the significant hypercalcemia. So primary hyperparathyroidism and hypercalcemia, usually patient can present as asymptomatic, incidental finding of high calcium, or they could be presenting with some of the complications of hypercalcemia, meaning nephrocalcinosis, nephrotheliosis, impaired renal function, or osteopenia or osteoporosis, specifically in the forearm. They could also develop with further complications like fragility fractures, some cardiac complications like ventricular hypertrophy, hypertension, arrhythmias, and some valvular calcifications. They could be symptomatic, which is not really typical nowadays because we screen a lot of calcium. We do a lot of calcium testing, which are the modes, the bones, which is not really, we learned them in textbook, but they're not really that much common. Our patient does have some sort of generalized weakness, which maybe could be related to the symptomatic of hypercalcemia. There are other causes of hypercalcemia, not only primary hyperparathyroidism, there's endocrine disorders with excess PTH production also, like hypothyroidism, pheochromocytomas, hypoandrogenism. There are the malignancy-associated hypercalcemia, which could be with elevated PTH-RB, or parathyroid-related protein, which is produced from solid tumors like breast and lung and kidney and GI, or could be produced by hematological malignancies like non-Hodgkin lymphomas or some other types of leukemias. You can have also malignancy-associated hypercalcemia with other systemic factors, like and with Hodgkin disease, you can have conversion of vitamin D to 125 dihydroxy vitamin D, and then you could have hypercalcemia with that. Cytokines by when you have multiple myelomas and malignancies metastasizing to the bones, and even ectopic real PTH production from ovarian, lung, or thyroid and thymus tumors. Other causes, granulomatous disorders, where it could be non-infectious and infections that related to the production and overproduction of 125 dihydroxy vitamin D. Some medications can induce hypercalcemia, like thiazide, excessive vitamin D, and immobilization, which maybe you've got a lot of inpatient consultations for patients with mild hypercalcemia. The main reason would be for them immobilization for a long time as an inpatients. The primary hyperparathyroidism in terms of causes, you have majority of the time it's a primary adenoma. Hyperplasia can happen much less, and usually it's part of genetic disorders like MEN1 or 2, and rarely you could have a carcinoma as a case of primary hyperparathyroidism. The indication for treatment or for surgery in patients with a primary asymptomatic hyperparathyroidism, this has been updated in the 5th International Workshop that was from 2022, led by Professor Belzikian. So the indication hasn't really majorly changed. Serum calcium, if it's more than 0.25 above the upper limit, or any degree of renal impairment or renal stones or calcium, excessive calcium excretion, that would be indication for surgery. When you have osteoporosis or vertebral fractures, that's indication for surgery, and if the age is less than 50. So our patient went for system EV scan showing increased uptake at the left lower border. And then due to the compression nature of the thyroid goiter, patient agreed to go on for total thyroidectomy and parathyroidectomy at the same time. Post-operative day 1, her corrected calcium dropped to 1.8, with PTH that actually was 9 and phosphorus increase above normal range of 1.5. That consequence, not really a good idea that this patient can be normal in terms of calcium levels, and this patient would probably be at risk for developing further hypocalcemia. She had symptoms of tingling in his hands and perioral numbness. So there are certain risk factors to develop post-surgical hypoparathyroidism, and usually when you have an excessive neck dissection and neck exploration, when you have a repeat neck surgery, when you have a Graves' disease, when you're not really, the surgeon not able to visualize the parathyroid glands. And what always we like to do is read the operative notes of these surgeons, see if they actually were localizing the parathyroids when they are doing the surgery. If the calcium level drops less than 1.88, the corrected, that's an indication, 24 hours after surgery is an indication that this patient most likely they will end up having a longer period of time being hypocalcemic. And if they develop bleeding after surgery also. So if the PTH level is more than 10 picogram, more than 1 picomole in the 12 to 24 hours post-surgery, that development of permanent hypoparathyroidism is very unlikely. Ours dropped to 9, so this is a risk factor here. So but the incidence of hypoparathyroidism after anterior neck surgery is about 8%. Some vast majority of them could be transient within 6 months, so about 75%. The rest could be permanent hypoparathyroidism. And there are certain features and symptoms of hypoparathyroidism, all of them related to hypocalcemia. You can have an acute presentation, you can have a chronic presentation. So if the ones usually post-operatively, they present as an acute, and usually they have neuromuscular irritability, and these could be numbness, twitching, spasms, and they could have some cardiac changes like prolonged QT interval. That's probably the most easiest thing to pick up. Chronically, they could have some extrapyramidal signs, dystonia, hemibelismus, and this is usually seen in patients with autoimmune hypoparathyroidism rather than post-operative hypocalcemia. And these are other causes of hypoparathyroidism. The most common cause by far is the post-operative, and this could be an acute or chronic presentation. Idiopathic would be the second in line causing or as a cause of hypoparathyroidism and hypocalcemia. Usually there could be an isolated phenomenon as an idiopathic, and usually it's an autoimmune disease, or could be associated with polyendocrine failure with other glands involved like thyroid and adrenal gland. There are a bunch of other reasons, I'm not going to go through them, but probably you're aware that there are other genetic, especially like pseudo-hypoparathyroidism, genetic syndromes like Diger syndromes, and some exposure to inflammatory disorders like iron and aluminum and amyloidosis. Management of symptomatic hypocalcemia, if they present acutely and they do have laryngospasm, bronchospasm, you need to act very fast. So calcium gluconate infusion, this is followed by bolus, followed by an infusion preferred. That's done in an ICU setting with a big central line. That would be the best way to deal with an acute setting of hypocalcemia. Once it's appropriate, you need to start and relatively early try to do that. Oral calcium and activated vitamin D, either calcitriol or alpha-calcidiol, depends on which one you usually use. If they do have other symptoms, not emergent symptoms, just like numbness and tingling, just like our patients, then we can do, for example, a calcium gluconate IV bolus, several boluses until the symptoms have been resolved, or we can start them on continuous infusion, run it through a 12-hour, even a 24 hours, but just don't let it just run continuously without having a stop at a certain period of time, because it can cause easily hypercalcemia. Also at the same time, as much as possible, if you can start oral calcium and activated vitamin D, that would be optimal for continuation of care. If they're asymptomatic, then it depends on their level of calcium. So if the calcium level is then 1.9, there is a risk of developing symptoms further on, and maybe you need to act a little bit fast. So you can do a calcium gluconate infusion and also add calcium and activated vitamin D. If they're completely asymptomatic and they have a mild hypocalcemia between 1.9 to 2.2, you can just do oral calcium. And these patients even you can do as a management as an outpatient with an activated vitamin D and oral calcium. Always, always correct magnesium, because magnesium deficiency can create this PTH resistant, and you might not really be able to get your calcium level within the target range, which is usually a low normal range of calcium. So this is what the goals of therapy is. You want to relieve symptoms of hypocalcemia. You want to raise and try to maintain the serum calcium concentration in the low normal range. You don't want to have it completely normal, because that then you can avoid the iatrogenic hypercalciuria. And you want to keep the 24-hour urine calcium below 250 milligrams in adult women and below 300 milligrams per 24-hour in adult men. You can add thiazide diuretics if it needed, try to lower urine calcium with that, and maybe even push the serum calcium up. That could be a helpful tool also. Avoid high phosphorus level, try to normalize magnesium as much as possible, try to keep vitamin D level within normal range between 75 and 125 nanomoles. This is conventional therapy for hypoparathyroidism, which depends mainly on calcium, and these patients are usually on ton of calcium tablets just to improve their calcium level, so they can be on from like 500 up to like 3,000 milligrams of oral calcium, preferably divided throughout the day on 3 doses. If you're using calcium carbonate, then you want to use it with or after meals. You can use calcium citrate in cases you don't need a specific pH for that. You want to use a vitamin D, either cholecalciferol or ergocalciferol. The most preferred and much available in the market is the cholecalciferol. You want to give a dose that you can correct a low vitamin D level with, and a maintenance dose at the same time. So usually they range between 1,000 up to 100,000, depends on how much dose you need to give and what's the level of vitamin D. But maintenance is usually somewhere between 1,000 to 2,000 international units daily as a maintenance dose. Calcitriol or alpha-calcidiol depends on which one you have and which one you have experience with. Kind of they give almost the same effect. Calcitriol usually longer half-life. You can dose it twice a day, even 3 times a day if it's required in certain patients. And you can go from like quarter of a microgram up to like 3 microgram a day. Thiazide diuretics, if it's required, you can start from 25 milligrams and you can go up to 100 milligram a day to try to improve the calcium and lower the urine calcium. Optimal monitoring for patients with hypoparathyroidism. So you want to check serum calcium, serum creatinine, calcium, GFR, magnesium, and phosphorus. So basically the bone profile evaluation. You want to do it every 3 to 12 months. It also goes back and depends on how actually you're regulating your patients. Are you doing changes in the regimen? Then you probably want to do evaluation after a couple of weeks from the management that you're doing. If he's very well stable, you can extend it up to 6 months or even longer. It depends on the patient condition. Also, you want to maintain vitamin D levels. So this is another evaluation you want to do over 6 to 12 months. And also, I would do like once a year, 24-hour urine for creatinine and calcium, making sure I'm not really overloading and pushing a lot of calcium in the urine to preserve the kidney and having less chance of developing nephrocalcinosis and nephrolithiasis. So management course with this patient show, despite adherence to treatment with 4 grams of elemental calcium a day in divided doses and calcitriol 1 microgram daily, she continued to have intermittent mild to moderate symptoms of hypocalcemia. She tried hydrochlorothiazide, caused significant hypokalemia despite potassium supplementation, which made the life is more miserable because now not only calcium and magnesium she needs to take, but also potassium, and with minimal benefit on the calcium level. So she would be a good candidate for parathyroid replacement therapy. So the consideration for using parathyroid replacement therapy is that when your patient is not adequately controlled on conventional treatment, meaning they still have low calcium, renal insufficiency, they develop poor quality of life, the compliance is an issue, malabsorption of these supplementation is an issue, or they're on very high doses of calcium that they have to take a large number of pills, that would be a good consideration to start parathyroid replacement. So the parathyroid hormone is an 84 amino acid, polypeptide hormone. And the only active region is the first 34 amino acid sequence. So the first 34 comes as a teriparatide, which we used initially as a treatment for her osteoporosis. It's been tested to improve calcium, and it does improve calcium and lower urine calcium, but you need to give it like twice a day in a chronic period of time, where they actually, the safety profile is only tested for up to 2 years. So not the best way to use this kind of therapy. So the whole sequence of the parathyroid, which is a recombinant human parathyroid 184, is the one that actually been tested for as a therapy for parathyroid hormone replacement. It's much longer in half-life and can be given as a once a day. and been tested to show that it can improve the calcium level, reduces the serum phosphorus, and also reduces urinary calcium. This is the REPLACE trial, which involved patients with permanent hypoparathyroidism. These patients, when they given NRAD, recombinant PTH 184, they were able, 50% of them were able to reduce their oral calcium by half, reduce their calcitriol also by half, and maintain a normal serum calcium compared to placebo. And on the other side, this is independence from the active vitamin D and reduction in oral calcium. About 40% of them were achieving that goal. This is the dose of calcium reduced by about 50% in patients using the PTH 184, and also on the other side you have active vitamin D dose in red. Also patients significantly reduced their dose. In terms of safety, pretty safe drug. They would notice some hypocalcemia, some muscle spasms, some headaches. Not something really was major with the use of this therapy. So she was given this therapy, and it was actually licensed for approved by the FDA in 2015, as well also in the EMA for management of chronic permanent hypoparathyroidism. So she started on the therapy. She was controlled. There's a 50, 75, and there's a 100 microgram dose. She was stable on the 75. She reduced her calcium requirements by significantly, by more than half. But then later on, what happens, and probably a lot of you know, that there was a recall about the drug, and this was not available anymore for her to use. So she resumed back her conventional therapy, unfortunately, which was not the best situation for her case. So in 2019, FDA recalled it because of solution contamination. The recall wasn't there, I believe, in Europe, but was not available anywhere in the Gulf, at least at this current moment. Another drug that's in the work right now is called TransCon PTH, and this has been tested in adult hypoparathyroidism. The main idea is that the patented drug is actually 134 PTH, which is teriparatide, but they linked it with a TransCon carrier, and this is actually a molecule that does not easily digested within the system, and it's linked with a linker. When it's exposed to a certain pH physiological levels at the blood, that linker dissociates, and then the carrier dissociates also, and then you have the patented drug in the bloodstream. That gives them a much longer half-life, and this is a way to give teriparatide in this form, and it was daily dose. And it was tested in the Path Forward trial, showing 3 doses of a TransCon PTH compared to placebo at the bottom. It was there was a randomized initial period for 4 weeks, and then an open label extension period, 26 weeks, and they're still working on the 214 weeks later on. So by week 4, 50% of these patients actually had the primary endpoint of reduction of calcium intake, reduction of activated vitamin D while maintaining calcium level compared to placebo, which is only 15%. 82% of these patients were able to completely stop oral active vitamin D and reduce the calcium supplementation to less than 500 milligrams. By week 26, which was an open label extension period, 91% of patients on therapy achieved independence from standard of care. There were no placebo at that point. Everybody was on therapy as in the open label extension period, and about 76% of individuals eliminated the active vitamin D and calcium entirely. This is the levels of urinary calcium also declined significantly before and after treatment with the TransCon therapy. Safety was very safe drug. There was no serious adverse events were noted. There were some headaches, nausea, fatigue, arthralgia, some elevated blood pressure, but nothing really was major to discontinue the therapy, even related to hypocalcemia or hypercalcemia. There are new emerging therapies working on for hypoparathyroidism specifically. TransCon PTH is going for phase 3 clinical trials. There is a long-acting PTH analog, which is a hybrid molecule between both PTH and PTH-RB homology, going to phases 1 and 2 trials right now. Work also on oral PTH molecule with recombinant, with human PTH 134. And there's a calcilytics, which are antagonists for the calcium sensing receptor. This can work well for patients who have an autosomal dominant hypoparathyroidism, and this is going also in the phase 2 trials. So with that, I end my presentation. Thank you so much for your attention.